Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Jim. How are you doing today?
Hey, very good. Thanks for inviting me.
Well, I definitely appreciate you coming on. Since this is your first time on the podcast, would you mind doing just a real quick introduction of yourself?
Sure. I'm Dr. Jim Ducanto. I'm an anesthesiologist in Milwaukee, Wisconsin. I've been in practice since 1996, since 97 in Wisconsin. I've had an interest in airway management from my even prior to entering the specialty of anesthesiology. And I really felt like I fell into something that became a calling. All anesthesiologists are airway experts. There's a few among us that just hold on to that passion and just make a decision and never stop learning and innovating, and I'm one of those people. So I've been a clinical anesthesiologist since 1996, coming up on 28 years, I guess, this year. But for the last 10 or more, I've been interested in pre-hospital airway management through my connections made through social media. Chiefly, those were with the Australians. They really fascinated me with how they integrated transport medicine into their system. I'm friends with a guy named Min Lakong out in Cairns. He used to work for Royal Flying Doctor Service. I'm not sure what he's doing now. Friends also with Yen Chow up in Thunder Bay, Ontario. He was medical director of one of the systems up there. And Yen and I get together, do simulations periodically, and teach together. So it's through this network of people, and that's where what led me to meet you at the SOMA meeting last week, Dennis. Is I'm just always trying to learn and see if I can offer anything. Generally speaking, you just really have to listen to what people's problems are before you can offer any type of a suggestion. But I guess we're going to have a nice discussion today, you know.
Well, I'm definitely going to be picking your brain on how to make decisions, and that's what today's podcast is all about, making what it seems to be a straightforward decision, which actually really isn't a straightforward decision, or can definitely be convoluted for certain. So just kind of jumping into things, where I see problems is people not having a plan. That can be across, I think, the spectrum of medicine as a whole. Is we know the procedure, the book indications, but when it's now slapping you in the face, it can be pretty daunting to actually make that decision and do the procedure, whether that be intubation or like a crike. So what I'd really like to dig into that brain of yours is, what is your decision-making process? So I'm going to preface this by explaining that chiefly most of my experience is working in a hospital, whether that's a small or large hospital. I spent most of my career in the largest private hospital in the state of Wisconsin, so we had a lot of very complicated cases, basically university hospital level care with the complexity of the cases. Prior to the creation of Sugamidex, which reverses rocuronium, we would occasionally have to reintubate patients in the recovery room, recovering from anesthesia. It's a funny thing that when it was argued that the drug Sugamidex was adding to the pharmacy bill, but a $99 drug was solving a problem that required an $800 ventilator setup and basically had the patient undergo what we would normally call a near miss. These people, the reason you're rescuing a patient in a recovery room and reintubating them is that if you don't do it, they're going to die. You can't put a price on $100. $99, $100 doesn't mean anything in the scheme of things. If in the name of patient safety, we're not reintubating patients after surgery like we used to 15,
years ago. So let's just talk about airway management emergencies that have nothing to do with muscle relaxants. Okay, so here's the thing. I'm an anesthesiologist. The first thing I'm going to do is a neuro exam. What we do in anesthesia is give medications to alter your neurology so you can undergo a procedure or be sedated so that we can care for you in intensive care, right? Mm-hmm. If I have a patient that has an injury and neurologically they're insensible and you can't communicate with them, the next question is, how long is this going to go on before we have to take the airway? That seems to be the expression that I picked up from you pre-hospital EMS military medics is take the airway. And what you really mean is that you're going to the cricothyrotomy. And as you were ramping up to discuss this with me, Dennis, you were talking about this with a sense of foreboding that individuals just aren't properly planning for this procedure. And when I think about this, because I trachely intubate with, of course, mainly now with video laryngoscopy, it's really not that a daunting thing for me to consider doing this. But you're explaining to me that in the situations that you're involved in, if you take an airway, that means you do a surgical airway. And that is understandable, that you don't want to have to do something if you don't have to do it. So number one, neurologic assessment. In the question list you sent to me yesterday, it says facial trauma. As you first see the patient, what indicators do you use to evaluate the patient? Essentially, pulse oximetry, visual, etc. The first thing I do is I assess their neurologic status. Is this person conscious? Are they arousable? What type of response are you getting from them? I actually really don't know how to do the Glasgow Coma scale. I'll be honest with you. I don't, I know you guys use that. I don't pay attention to that. To me, it's a lot simpler. Are they arousable? Are they somnolent? Are they sonorous breathing? Are they obstructing their airway? Do they need, I don't even know if you have an oral pharyngeal airway. I know you might have nasopharyngeal airways, but you may not want to use it because you're assuming you've got a broken nose or a disrupted nasopharynx. You've got several things going on here. You're going to have to literally assess what it takes for you to safely care for this patient. So let's say this is somebody who's unconscious, and you're going to position them in the recovery position or what have you. If they're bleeding, they'll evacuate their own airway contents. The blood will come out of the nose or mouth or whatever. You're going to have to give that patient some time, and then you're going to have to think to yourself, okay, how long is too long to wait to see if this person wakes up? Because if they're not waking up and they're not tolerating their secretions, they're aspirating their blood, they're aspirating their secretions, things just don't look great. So in a hospital situation with horrible epistaxis, I can get an emergency physician or an otolaryngologist to place a special nasal packing in. They call it the rhino rocket, which would stop the bleeding, or maybe it would stop the bleeding. But we have gadgets that we can use, and you don't have that gadget. Okay, you don't have the ability, you don't have the equipment, and you don't have the training. And actually, I don't know how to use a rhino rocket. I just know they exist. You're going to have to just be honest. You're going to have to take a look at this person. And then, of course, I do a little bit of emergency medical systems education with Mid-State Technical College up in Wisconsin Rapids. And when the paramedic students first assess a scene, when they're verbalizing in their exams, they say, is the scene safe? So I'm going to ask you, take a look around. Is the scene safe? Do you need to move out of this area? Where are you? You guys are probably climbing mountains or something like that. Are you stable to take care of this patient? What do you need to do? Do you need to get them off a ledge? Do you need to make sure that you don't get crushed by a rock slide? Maybe it's wintertime, it's avalanche season, or it's bear season, man. I don't know. Right. Is the scene safe? Okay. Take a look around. If the scene isn't safe and you got to move and the patient can't be moved, then you have to make the patient movable. What does that mean to you, Dennis? If I say to you, we got to get the hell out of here, and this guy, we can't move him in his current state, what does Dennis say to me?
Dennis says, let's go. And if he's not standing up, I drag him or pick him up and move.
You drag him. And if his airway is, as they say in Germany, verschissen, are you going to push ahead and just do the definitive airway? because you know you got to get out of here, and that you basically you can't look back. You got to leave.
I mean, depends on the threat, and the threat can be all the above. So that can be violence, that can be environmental threats. It really doesn't matter. If it's time to go, generally it means we have to leave now. And if his airway is not secure, I'm probably saying a prayer. We're getting to a place where I can stop for a minute or two. And if I'm playing that game, I'm going to just take his airway as soon as I possibly can.
Okay, great. So, let's move back to the hospital for a moment. I work at a level 2 trauma center, and I'm kind of amazed as to what types of cases come to us. I'm thinking to myself, why are you bringing this patient here when 20 minutes down the road, we're actually like 7 minutes by helicopter is the level 1 trauma center. But you look at a patient and you say, okay, what are we going to do with this patient? We can't do any further diagnostics, like CT or, whatever, if we don't intubate the patient. Okay. It's a little bit, I mean, it is a bit different from what you're talking about, but
Sure.
you have to just take a look at the patient. Is this person, what are they doing? What are they doing? I had a patient that was actually tolerating an oral airway and a face mask with a severe injury, and the surgeon wanted me to intubate the patient, and I was hesitant because I didn't really think we had actually done proper assessment and resuscitation of the patient prior to the intubation. I understand that is that happens all over the place. That happens all over America, probably all over the world. But what I'm going to assess is, and I don't know what type of vital signs monitor do you have. You say you have pulse oximetry. I think, I mean, that's easy. That's a small thing. Do you guys check a blood pressure on an injured patient out in the field? I'm just wondering.
We have it. It's how close, like you said, how close to the danger are you? If you're pretty close, then more than likely you're going to get a pulse, radial pulse, carotid pulse, femoral pulse.
You know, the reason I ask you this is, for some reason it comes into my mind that you're going to do RSI, but you're not going to do RSI in your case. So in many ways, you know, you want to know if they're alive.
Yes.
You don't want to make it worse. Right. Yeah. So this is a discussion where I might learn more from the discussion than you may learn from me. But I'm simply saying, neurologically speaking, if your patient's neurologically incompetent, they are completely dependent upon you. They're completely dependent upon you. You just have to look at them and say, if you're completely dependent upon me for your airway and you're not going to maintain it, I have to do something about this. And if simple postural positioning is not doing it, you're going to have to let that voice in the back of your mind begin to get louder and louder. Let's not delay this, because this is not something, you're not putting a dialysis fistula into somebody. You're not putting them on ECMO. You're not opening their chest and putting them on cardiopulmonary bypass. You're performing an airway management procedure. Go back 100 years on the battlefields of France. If you had any type of a wound to the head or neck and you needed an airway, they just did a tracheostomy. They being, of course, they had physicians and military medics that would do these. Probably the physician, I don't know, you know, if there were medics back in World War I. They may have, I know that there were surgical teams. As a matter of fact, Dr. Sidney Yankauer, for whom the Yankauer catheter is named, went to the battlefields of France with the staff of Mount Sinai Hospital in 1917. And he did head and neck surgery and took care of war wounds and all that other stuff. Then went back to New York City after the war. I know there were surgeons there. So if you're the one, then you're the one, and this is your day. And I don't think it needs to be very, very complicated. And I'm not talking about a neuro exam the way you would. Well, I am talking about a neuro exam, right? I mean, how do you do a neuro exam? You assess the patient. Hey, how are you? Shake, shake, shake. No response. I don't know if you would do the thing like rub their sternum and see if they localize the pain, withdraw from it, or decerebrate or something. I mean, you can get a lot of information from that. So it's a neurologic exam, you know. If you have a pulse oximeter, I think that is really going to give you the information, because it's probably going to tell you if, number one, they're aspirating substantial amounts of blood. because their saturations will drop. Number two, it'll tell you if they've got their respiratory efforts are inadequate. You should be able to probably figure that out just by looking at the patient. But I don't know what conditions you're in. I mean, I would assume that everything would be just as quiet as the room as this podcast. And well, I met you at Soma. I'm sure it was pretty loud. It might get pretty loud in the places where you go. You may not be able to hear anything. You might be wearing literally hearing protectors,
Yep, yeah. Absolutely. For SpO2, what would be a number that I'm taking it if it's this number or less?
I don't know. I think once you get under 90%, I think that you probably have a very, very good chance of saying, okay, now there's a lot of things going on here, but the respiratory system looks like it's going to be screwed here very, very soon. They're going down. Yeah, absolutely. They're going down. I think once you get below 90%, unless you're, of course, at like 14,000 feet altitude or something, by looking at you, I would think, gosh, maybe you go to the gold mine at the top of the Andes or something and hang out up there.
So, I mean, obviously, SpO2 less than 90 or less.
Yeah.
It does not take long for somebody to start desaturating if they've moved from, normal 98 all the way to 90, in a short span. It just accelerates, exponentially after that. So you got to be, I think that's part of the problem is guys, like we know, the book answer. I imagine most medical providers know the book answer, but they haven't made a plan in their head that if the kind of an if-then type statement, if this happens, I will now do this procedure.
Yeah.
I don't know. I don't know if that's universal, but.
Yeah, I think if you and I were to simply say something as quite simplistic as enough is enough, this has gone too far, it is time to do something, or, you just have to accept the fact that you're not going to save this person.
Right.
When we talk about cricothyrotomy in hospital medicine, in difficult airway management, there's a concept here that I would like to say that I'm not so sure anybody in my branch of medicine would appreciate, but maybe someone in your branch of medicine would appreciate, is you should perform the cricothyrotomy before the patient is dead.
Yes.
Okay. We're doing, of course, we've got all the tools. And we're going to try all these tools, but when the tools aren't working, so the flexible fiber optics are not going to work in the presence of blood. Video laryngoscopy can work in the presence of blood if you use proper suction techniques, but if maybe it's not your day, maybe you were too aggressive. Some people get very excited, and when you get very excited, you make mistakes. What is your guys' favorite saying about slow is smooth, smooth is fast? What is it?
Right.
What do you say, Dennis?
Yeah.
What do you say?
You got it right. Slow is smooth, smooth is fast.
You get excited. Yeah, you skip over steps.
Yes. Yeah. Especially, if you haven't done planning as far as your kit goes, But so one kind of example that I get brought up a lot is, like we mentioned, facial trauma. So that could be self-induced shotgun blast to the face. That could be shrapnel or whatever. But the face has been disrupted, and guys will say, well, I saw one in the hospital and all we did is sit him up and we didn't have to take his airway. He was fine that way. I think that was good. That was a good example. However, that might not be the rule you want to base all your airway judgment on, is this one time in band camp.
Yeah, well, that is a very good way of describing it. It is band camp. You're not on stage at Summerfest here in Milwaukee in front of 15,000 people. You've got to perform. So when you're in a hospital, you've got the backup of other professionals at your level or higher. You have monitoring, you have oxygen, you have suction, you have lights, you have safety. Everything I have The only thing you have that's similar to that, you may have some oxygen, but not much.
Yep.
You may not even have suction, and you may have poor working conditions. I mean, you could complain about this. So you guys you should complain to someone you have poor working conditions. I'm joking, of course.
Right.
But you sort of asked for this by leaving the metro area. You should never have left the city. Or
I say that all the time.
As they say in the movie Apocalypse Now, never get off the boat.
Right?
Anyway, okay. So, these are apples and oranges. And even in my opinion, emergency medical service airway management is apples and oranges. So what type of a checklist do you want? Okay, your checklist is pretty solid. Is this person ambulatory? Can they protect their own airway? Let's say they're not ambulatory. They've got lower extremity wounds, fractures, whatever. Are they neurologically intact enough that they can communicate to you? How are you? How are you doing there? Says, oh, I'm okay. Says, here, can you hold this to your face? Can you hold direct pressure on your face? Can you do this? Are you able to spit that blood out of your mouth? How are you doing? Mm-hmm. Okay. Let's say you've got somebody who's deteriorating, and I'm going to use the name Mr. Baldwin.
Okay.
Mr. Baldwin sustained a gunshot wound. Unfortunately, the bullet bounced off the camera and came back at him and got him. Okay, Mr. Baldwin, hi, I'm really sorry this happened to you. My name is Dr. Jim, and I'm here to help you. How are you doing, Mr. Baldwin? He says, I'm having some difficulties breathing. He says, okay, all right. Can I put you in a better position? Can I sit? Is this helping you? Is this helping you? It's helping a little bit. We're going on. I say, I'm going to keep talking to you. I'm going to keep checking in with you here, Mr. Baldwin. How are you doing? How are you doing? And labored breathing. The guy stops answering you. He's breathing. He's beginning to go out. He's beginning to go down. You say, hey, how are you doing? You hear him gurgling, all this other stuff. You say, okay, look, Mr. Baldwin, this is a pretty serious wound you got here. And what I'm going to prepare to do for you is to help you breathe. And this is going to be something that's a little bit unusual, but it's for your safety. So what I'm about to do is I'm going to position you so that I can get at the front of your neck, and I'm going to be grabbing you with my two hands. I'm going to be making a small incision in the front of your neck and placing an airway into your windpipe so that you don't have to worry about choking anymore. And you can be tremendously calm and direct and just tell them exactly what it is you're going to do. You're feeling my hands now on your neck. What you're going to not feel now is you're going to feel the sting of a small cutting instrument. Here we go on the count of 3. 1 and 2 and 3. You're going to feel me putting my finger into the wound and feeling around in your neck. And now you're going to feel a big release of air, and you're going to cough out whatever's in your trachea now. Scalpel comes in alongside the finger on the cricothyroid membrane, inserting you through the cricothyroid membrane. Your finger goes into the cricothyroid membrane. I said, you're doing pretty good here. Keep coughing, keep breathing. You're doing fine. Everything is going well. We're going to get you through this. You're going to make it. Here we go now. I'm going to place the tube now. 1 and 2 and 3, and in goes Mr. Tube. Okay. So now you've criked Mr. Baldwin. We went from someone who was answering us to somebody who is deteriorating both neurologically and respiratory function in terms of respiratory function and the ability to protect their own airway. So you continue to talk to the patient. Even if the patient's unconscious, you keep talking to them, because what it does is it puts you in a position they can still hear you even though they are unconscious. They can still resist you although they are unconscious. You put them in a position where they will cooperate, and they'll make the procedure easier. I had a patient once that came to mind that was in severe respiratory distress in a recovery room. It was not my patient, but I responded to the patient, and I placed a bag valve device mask over to the patient's nose and mouth. I began to try to help them breathe, and they were fighting me and fighting me and fighting me. And this is going to sound kind of crass, but I think you guys can handle it. I leaned in close to his ear and I said, hey, I got to say something to you. if you keep resisting me, something really bad is going to happen to you. And the guy relaxed and he allowed me to face mask ventilate him. And I know this kind of it sounds kind of like a jerk move, but I just had to tell him completely the truth. Stop yelling, sir, relax. Bullshit. There's no such thing as relax. The guy is struggling to breathe. He thinks he's going to die. I just told him the truth. I said, if you keep resisting me, something really bad's going to happen. So stop that shit now and let me help you. Okay. And you can, I'm sure you talk to each other like this. I mean,
yes.
I can't imagine it. Just tell each other the truth.
Right.
Says, hey, you look awful. Let me help you.
Right.
Yeah.
Yeah. And I mean, I think probably most people who aren't anesthesiologists kind of forget about that. The patient goes unconscious. They can still hear. Once they're in that stage 3, essentially hypoxia is giving you that stage 3 anesthesia for you. But they can, that sense of hearing is the last thing to go.
And they can still resist you even though they're not conscious. Most of what we are, this is going to sound kind of weird, is not the brain above our ears. It's the brain below our ears all the way to our toes. It's our spinal cord. It's our reflexes. You guys are all athletes. You lift weights. You run like hell. You practice like kung fu, jujitsu, who knows what, MMA. Who the hell knows? I mean, you don't even know what's in that person's nervous system. If you tweak the wrong thing, they're going to get punched 3 times in the face and like slammed to the ground. And I put a kung fu master to sleep once with a gas mask because I couldn't get an IV in the guy. This is like 20 years ago. And just as I'm getting him down with halothane or something like that, the guy does some type of weird kata. It just looked awful right in front of, right over the top of himself. And what I did was I bent down underneath him and held the mask with 2 hands, nice and firm, until I could gas this guy deeply enough to get so that his kung fu went to sleep. But the kung fu came as he went under. Yeah, I've seen it. And one of the nurses was going to step up and grasp him by the wrist, and one of the monitoring techs in my department just put his hand up and stopped her and says, "No, leave him alone." Yeah, because the nurse was going to get crushed. Yeah.
So, we talked about a little bit about when somebody needs like an emergent airway.
Yeah.
Okay. Their LOC is declining. SpO2 is declining. Like, we need to stop this train now so that we can start wheeling him back towards living, right?
Right.
I think another kind of difficult situation is, it's not good. There, like you talked about before, he's able to talk to you.
Yes.
And then it slowly starts to, he's not breathing so well. And then pretty soon he's using 1 or 2 word sentences. And then, and just that slow roll. How long, I guess, are you willing to, use all your other tools, like getting the oxygen, changing position, getting, escalating your force until you're like, none of this is working? Do you use the same type of criteria? Hey, SATs are less than 90. I'm going.
I think if you what limited monitors you have to use.
Yes.
We all love numbers, let's say that you decide to buy the cheapest pulse ox in Walgreens and use that as a clinical monitor, and then you have to ask yourself, do I really trust this thing? I don't know what your situation is, because when COVID hit, I think I had access to 2 actual pulse oximeters. Mm-hmm. And then we had the cheap ones from Walgreens, and I never trusted those things as far as I could throw them. And I got to be completely honest with you. You get what you pay for. So we're looking at this thing. You're looking at this thing. You don't like what the gadget says to you. Is it on the finger? You're going to readjust it on the finger. Yes, the damn thing is still giving you a poor reading, or it's not giving you any reading at all. Now you just got to just say, all right, now we just got to make a clinical decision, like, all this technology, it's not working. for all we know, it's snowing or it's raining and water got in the device. Who knows? Or maybe you're in a cold environment and the digits won't read. What can you do? Well, what you can do with some of these monitors, and let me just say that you could take the pulse oximeter off the finger and you could quite literally stick it in the mouth. You can fish hook it right into the cheek. If you're a veterinarian, you're taking care of a dog, you put the pulse ox on the tongue. No, that's not going to work in a human. Most of us don't have tongues long enough to work. I'm joking, of course. Yeah. Okay. So it really, this becomes a clinical scenario. This almost sounds like a really interesting but possibly a very boring simulation video that needs to be made to explain this, because we have to sort of kind of look at the levels of injury to a patient, the way I described in my little narrative with Mr. Baldwin. Okay. What does this look like? I think you guys know what this looks like because you've seen it. So I'm simply telling you, you know what? You don't have to listen to me. Trust yourself. Look at what the clinical information is. Where was it that I saw this thing written down that no one is coming to save you? Is that a military medic thing or is that a paramedic thing? What is that?
I mean, it could be either, but it's true with us.
No one's coming to save you. You are it. You're going to have to, make it work. You're going to have to, if you're the person, you're the only person that is there to do what has to be done. You got to do it. Don't regret not doing something that you should have done. So, it's a tremendously simplistic thing for me to say, but it applies to, the most advanced, care and medicine you could ever think, gosh, why did you wait so long to intubate that guy? Why, whatever. Well, maybe you've got a good reason, but in an emergency department, I can put on a non-invasive blood pressure cuff. I can put in an arterial line. I can monitor the patient. I can look at the heart rate. I can look at the respiratory effort. I can visit, generally speaking, in traumas, we don't take advantage of elevating the head to bed, which is kind of a bummer. But you're always worried about, spine injuries and stuff. I hope I'm helping you with these comments, Dennis. I don't know.
Absolutely. Absolutely. Okay. And I had a question and now I forgot it.
Well, I'm sorry.
That's
it'll
okay.
Come back to you.
Yeah, eventually it'll come back.
Yeah, it'll come
back. That's okay. So I'll think of it here again soon.
Sure.
But, with all this, needing decisions, one of the things I talk about with my students is you have to have your gear set so that you have everything available for you to now make that decision. So,
right.
When guys come up with their cric kits, or I'm sure, paramedics have their intubation kits, it's not just a tube and a scalpel and a 10 cc syringe. Where's your suction? Where's your securing device? Where is your, et cetera, et cetera.
Yeah.
If when you believe that maybe in a more planned airway, hey, I'm going to use lidocaine to numb the site, so I can make the whole situation more comfortable for the patient. Where is it, right? And I want that. So I think if you have a planned, more robust airway, it just allows you to be more prepared and more confident going forward, and not constantly having to run back to your bag or have somebody run and get you something, so you can act.
It would be fabulous if you had access, you all being the listeners here, you have access to commercial kits that supposedly have everything in there. And I realize that some of these things are quite expensive. I don't know what things go for, but generally speaking, I've seen cricothyrotomy kits on the order of $200, $250. And I've seen a few nice ones. And I have my own little conflicts here with what I would recommend, so I'll recommend none of them. Okay.
Okay.
I'm not going to, I do actually VBM from Germany. Oh man, what a beautiful kit. That is generally to, I don't think they're really, I didn't see them as a vendor at, Soma. So, the VBM is the people who actually brought what we call the King laryngeal tube to the United States. The King tube really is a German product, by the way. It just so happens that King Systems in Noblesville, Indiana marketed it in the United States. That's why we call it a King tube, and Ambu bought them about 5-6 years ago or more. So Ambu has the laryngeal tube. People still call it a King, but whatever. So, okay. So, yeah, I don't want to go off on too big a tangent here, but, if you're going to build your own kit, it basically should look like what it looks like, in the book. You're going to have a scalpel. We're going to recommend you have a bougie, or something. I mean, quite literally a bougie. What is your technique that you're recommending in your community, Dennis? Are you doing a scalpel finger bougie, a scalpel, bougie? I mean, like, where you put the scalpel in and you almost use it like a crike hook and then you slip the bougie around it, that kind of thing?
I mean, I've seen all the above.
Yeah.
And I've seen people switch techniques midstream, and usually it's because they had never practiced with either of them. One thing that I like having essentially bomb-proof plans to the most of my ability. So I'll use like the mosquitoes, and I'll grab the lower half of the cricothyroid membrane, and once it's clipped, like you're not going to lose the airway unless the mosquitoes like shatter somehow, which has not happened yet. But
I'd have to see you do that to understand exactly how you're doing it, because there's a few things that pop into my mind, but that's not important. This is very interesting. I've only, there were 2 crikes I was involved in. One was when I was still in training in Chicago, and the other one was, at my hospital in Milwaukee. And the guy who did the crike was the otolaryngologist. He was performing an endoscopic sinus surgery for, nasal obstruction, but, I don't think he did a very good pre-procedure exam, because after we anesthetize his patient, my colleague places a glide scope into the pharynx and we can't find the larynx. We cannot find it. And he says to me, "Jim, well, do you see anything?" I say, "No." So he wakes the guy up. He lets the succinylcholine wear off, and the guy has a complete airway obstruction and he loses the airway. And right before this happened, I said to the otolaryngologist, based upon what we just saw, you may actually have to do a surgical airway on this guy. And the guy's like, "What are you talking about? This is an elective outpatient endoscopic sinus surgery." I says, "I'm telling you." So anyway, we lost the airway. The otolaryngologist took the scalpel and he took it straight across the neck like he was trying to transect the entire trachea. And I looked at that incision and I said, "Holy shit. I have never seen an incision that big for a crike." And I realized, because he's an otolaryngologist, he's going to put a Shiley trach tube in, because that's what he's thinking about. So he made the incision massive. So I grab a bougie, I put it in there, I put in a 6-0 tracheal tube, we resuscitate the patient. Then he immediately does a proper tracheostomy and takes out the crike and sews up the cricothyroid membrane. And the patient ended up having nasopharyngeal carcinoma from his nasal pharynx all the way to his larynx. And that, I mean, that was just, that's like, you never see that. It happened to me. There's literally 9 years ago that happened to me. And, it's a funny thing. I had actually delayed, inducing a patient for a knee arthroscopy to go down the hall to help a colleague. And I says, "You guys, I'm sorry, but my colleague down the hall is having a big problem here. I got to delay this operation for about 10 minutes. And, after that, I came back and put the patient to sleep and on with the day I went,
Mm-hmm. So speaking of that, I finally remembered. So I think one of the hang-ups or the hesitations is you guys don't really know what happens after you've done the crike. And I'm not talking about, what kind of sedation or things like that or pain management to keep in place. I'm talking about when this thing comes out, how hard is it? Is it a big deal to, once we take the tube out, is he going to have a massive scar? Like, have I damaged him forever? Type things.
Geez, it's a weird thing, but wounds in the neck, generally speaking, no, I don't. This is not a problem. As a matter of fact, the dang thing you guys are also pretty darn young. These things heal up. It's no big deal. And if it looks wrong, it looks bad, the proper type of physician can sew the cricothyroid membrane shut. You just sew it shut. It's like, well, it just makes complete sense to me. That's what my otolaryngologist colleague did. He just sewed it closed. It's like, wow, okay, that's cool, man. Yeah. Did it disfigure the guy? No, not at all. The thing that the thing that we would worry about in proper medicine is, do you get subglottic stenosis, et cetera, et cetera, et cetera. I don't know. I doubt it. This is the sort of thing that happens to people that have poor wound healing or wonky wound healing, and that if it does happen, it can be treated by a proper physician. But this is not something, you're not scarring somebody for life. You're not performing a field amputation here. This is something that that's going to heal, just like a broken windshield on an automobile. You just call insurance people, and Glass X or whatever shows up, fixes a windshield.
Right. So when it comes to like airway management, let's say maybe you're talking to your residents or whatever young physician is coming into the field, what kind of advice would you give them to medics when it comes to principles of like airway management?
God. That might be a little bit hard for me to answer. Maybe it's a really easy thing for me to answer, but the real answer to this is that the very basis of what it is that we are and what we do, you have to realize what you guys are. You guys are physician extenders by virtue of who and what you are. You are an extension of physicians. And a physician takes care of a patient by examining. You have to look, you have to listen, you have to examine. Sometimes you don't have to touch the patient to do that. Maybe most of the time you don't have to. It shouldn't be too difficult to tell what is wrong with a patient, especially if they can talk to you. It shouldn't be too hard to figure out what's going on if they can't answer you. For all you know, somebody might have gotten into, this is not a problem in the modern day and age, but here I am in Milwaukee, Wisconsin, and I went to the local history museum, and I found out that when Prohibition hit the United States circa 1918 with whichever amendment it was, like the 18th Amendment, or I don't know what it was, one of the big problems was that, of course, people didn't give up alcohol, but they started tapping into industrial supplies of alcohol that actually were poisonous. And actually, the government knew that this was the case, and they actually did not do anything about it. They let it happen because they figured it would discourage people when they got injured or killed, right? For all you know, somebody got into something really, really, really bad, and it may be a drug, it might be alcohol, who the hell knows, or maybe even they were poisoned. You guys also deal with gaseous weapons of war, and I don't mean farts. Yep. I mean, it may just go down. You got exposed to a chemical weapon. You should be able to take a look at somebody and just do a physical exam. If they're twitching and they're salivating. My brother, who was in the Marine Corps 1980 through 86, so he was mentored essentially and trained by Vietnam veterans. He was in the Marine Reserves, and they deployed to a lot of places that nobody talks about, from the Philippines to South America, Central America. If you see somebody who's convulsing, it's too late for that person. You put your own gas mask on first, and then you go to them and you give them the antidote. But chances are, if they've gotten that much in them, they're done. I mean, that's what my brother was taught back in, this is 40 years ago, and I don't know how it is today. Maybe you guys have better equipment, better recognition. Even the firefighters have, they walk around your house with, I had to call, here in Wauwatosa, Wisconsin, I had to call the fire department twice in about 4 years in 2 different houses for carbon monoxide. And when they came in my house, they were carrying gadgets that could sense 7 or 8 different gases. And I mean, maybe in military medicine, you guys have those gadgets that can sense that stuff, weapons of war or whatever, or even just toxic stuff. And actually it was the same engine crew that showed up both times. It's kind of funny. In one case, it was, my furnace died in the year 2000, and it died. I was microwaving pizza. The carbon monoxide detector in my kitchen went off. I pushed silence, microwaved the pizza. The thing went off again. I pushed silence again. The thing went off again. So I pulled it out of the wall, finished microwaving the pizza, went down to the basement, checked the other carbon monoxide detector that was read 67 parts per million. Right. So then I called the gas company. I don't remember who I called. But basically, I called somebody, and then the fire department showed up, and they said, "Yeah, man, you got to get out of here." And I called the number on the side of the furnace, and the number was CA6 6700. The furnace was so old, it had those 1940s phone numbers on the damn thing. And so the guy answers the phone at 7:00 at night. I don't even remember what day it was. And it's hey, is this the Liberty Furnace Company? Says, "Oh, we bought them 7 years ago. What can I do for you?" Yeah. And the guy says, well, I said to him, "Well, hey man, this thing is dead. It's belching carbon monoxide in my house. It's 10 or 12 degrees below zero." And I said, "Dude, I need a new furnace." He says, "Okay, we'll be there in the morning." And those guys showed up, threw the old furnace on the driveway, installed a new furnace, and the problem was solved by 10 o'clock the next morning. And I was like, oh my God, I can't believe the level of service I got out of everybody. Fire department, furnace people. I know this is kind of irrelevant to what you guys do, but it is what it is, Yeah.
But I definitely think, as far as advice, like you said, just do a good physical exam. It's kind of like pornography. You know it when you see it. Somebody needs an airway. Don't be afraid to take it. Those things can always be walked back.
Yes, exactly right. There are those among us that we see something awful like that, and they will turn around and go the other way. But you guys were trained to step in when other people leave. And they say the same thing about people in the fire service. These people rush into burning buildings, and all the rest of us are running out. And the thing with paramedics is that they get hit by cars. You got to be really, really careful, or stuff happens. I was watching something on Instagram where Highway Patrol is doing something, and there's a flatbed truck on the other side of the highway. The ramp is down, and someone flies up the ramp at highway speeds, and the car flips over. That was just spectacular. But somebody was looking at their cell phone, wasn't watching what they were doing, and they drove up the back of a flatbed truck ramp on the other side of the highway. It's a good thing you weren't standing in front of the truck.
Right.
That could have happened to you.
Yeah. Yeah, absolutely. Oh, cool. Thank you, Jim. I really appreciate it.
You're very welcome. I hope this has been helpful. I don't know, man.
No, I appreciate it.
Yeah.
Cool. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.